Well, welcome back. It's time for us to have the discussion regarding your health, and particularly we are looking at a recent survey by the Kenya Population-Based HIV Impact Assessment that, of course, has revealed that at least 1.3 million adults are living with HIV and AIDS and about 139,000 children. And we just really want to try and understand how different is this particular survey and what really does it mean in terms of trying to guide policy going forward, and is it really possible to end the HIV problem in the country? And for more insights on that, I'm now joined by Dr. Catherine Ngugi, who is from NASCOP, the head of NASCOP at the Ministry of Health, as well as Peter Young, who is from the U.S. Center for Disease Control and Prevention. It's good to have you in studio this evening.
It's great to be here.
Let's talk about the numbers, the survey that you carried out. What really is happening? Has HIV prevalence rate gone down, or what are we looking at?
Well, the HIV prevalence rate has come down a little bit. The last survey was conducted in 2012, and in that survey the prevalence in adults was 5.6%.
Yeah.
And in this survey we found a prevalence of 4.9%. So it's a modest reduction in prevalence.
What are some of the factors that perhaps have brought it down?
Well, we hope that it's due both to a reduction in new HIV infections, and I think that's actually probably the more important finding from the survey, which is that the number of new infections has reduced from about 106,000 in adults in 2012 per year to just 36,000 in this survey in 2018.
Catherine, which interventions has the Kenyan government been employing?
Thank you. The HIV program at the national level has put several measures and interventions to ensure that at least we are able to have the achievements that we have had. One of it is scaling up of antiretroviral therapy to our clients all over the country, and even bring in regimens that are able to help us to reduce the virus to a level that at least we're at 4.9%. But as well helping clients to be able to know their status of the HIV. Different measures, like now we have introduced HIV self-testing, and as well like the voluntary counseling and testing that they are able to be done. We have introduced as well PrEP, that is pre-exposure of prophylaxis, to ensure that clients who are at risk they're able to be prevented to get the transmission. Yes.
In terms of stigma, has that gone down?
Yeah, because you see, over the last decade, we have had quite strides, good strides that HIV is no longer the HIV that was 10, 15 years ago. And we have been able, at least, it's now a chronic disease. No longer that if you acquire the HIV and you're diagnosed, that you're worried. But now you can, when you are linked to care, you're able to take up your medication and be able to live a long and healthy life. Yes, and continue with the normal duties. Yes.
Peter, what did this survey focus on? What were the key areas that you were focusing on?
Well, the survey focused on many different HIV indicators. We talked about prevalence and new infections or incidents. But three other important indicators that it focused on were the knowledge of status. So among people living with HIV, what proportion of them know they're HIV infected?
What were the numbers like?
Well, we found about 80% of people living with HIV know they're infected in the case of adults, and even 80% of children, their caregivers are aware of their status. So that was good. That was up from 56% in 2012.
All right, mother-to-child transmissions, what do the numbers look like? Because that looks like good news.
Okay. Unfortunately, for the KenFIA report, we don't have really the mother-to-child transmission rate from the KenFIA report. But from the programmatic level, at NASCOP level, we have the data that shows that currently we are around 11%. And it's a good achievement, knowing that around 2018 we are around 12.4%, at least good improvement so far.
So why didn't you focus on it with this particular report?
You'll come to, in epidemiology, of something like the sample size that we got from the households that we had could not be significantly, was not powered enough to be able to give us the numbers that we could really say well. However, when we asked the household that we went to, the mothers who went to the antenatal clinic, almost 94% were able to know their status. and the ones who were HIV positive, they were able to be linked to care. Unfortunately, 88%, around 7.9% of the ones who have been diagnosed HIV positive in antenatal care were not linked to care in terms of to take the antiretrovirus to ensure that they prevent the mother-child transmission.
So it wasn't easy
so
to make
it's a
the
gap.
connection.
Yeah, so it's a gap that we have noticed,
Yeah.
and definitely we are doing something to ensure that we address it.
Okay.
Yes.
In terms of the difference of this particular survey from what we've been seeing in the Kenya AIDS Indicator survey, what really are the different distinctions?
Well, this survey, in many ways, the KenFIA survey and actually all of the FIA project, which is a multi-country project, was modeled on the KAIS surveys, on the Kenya AIDS Indicator surveys. Those were some of the first surveys to really look at that cascade of care, looking at whether people know their status, and those who know their status, are they on treatment, and have they achieved what we call viral suppression, meaning that they've controlled the virus and it's very unlikely they'll transmit it to somebody else. So this survey also looked at those same indicators. One of the differences is that this survey, we really kind of brought it to the community, and the testing was done in the household, and the results were returned to anyone who consented to participate and to have their results. They were returned the same day in the household, and then other more complex tests were of course done in the laboratory, and those results were also made available to the participants.
Were people willing, to participate in this survey? Because I remember when you were launching, you did a lot of sensitization on, people come to your house, they try to, have you tested?
We had the response rate was around 77%, which was quite really good. Among the 70,000 households that went, it's around 34,000 persons, which is a very good.
In 47 counties.
In the 47 counties, which was a very good. It's a good response rate. Yes.
What were some of the challenges that perhaps you experienced on the ground?
Maybe I could, well, I think going back to your previous question, one of the big differences with KenFIA is we did manage to get to all 47 counties.
Yes.
The KAIS survey didn't manage to reach all 47 counties for various reasons. So that was, I think, really a good, it was an accomplishment. Some of the challenges, household surveys are inherently challenging. You're going into somebody's home and asking them very personal questions about sexual behavior and HIV. But as my colleague mentioned, we did have a really good response rate in KenFIA, so we're confident that the results are representative of the country.
All right. In terms of now, the results that you have, how are you planning to use them in terms of guiding policy going forward?
Okay. First, I think one thing to note is these results, the KenFIA ended by February 2019. So we already started using the results internally. This was just the report, finally to produce it. And so one of the gaps that we noticed, for example, is the pediatric viral suppression, which was 67%. And so...
that is among children.
That's among children. And so, yes, that was at February 2019. Now it's February 2020. Yes. Okay. Now we're at 83%. So we are good. And the other part is we noticed, and I think when you go deeper into the results that we have, the demographic, looking at the ages between 20 to 34 of male and female, we find that the prevalence is 3 times between females and males. And so we have realized that adolescents and young persons is a group that we really should focus on in terms of ensuring that they know their status, and we link them to care, ensures we can have them reduce the virus and prevent definitely the transmission. Yes.
What about in adults? What was the suppression viral suppression rate?
Yeah, okay. In adults it's 90%, which was very good. In fact, comparing adults and pediatrics, adults were doing very well in terms of the second 90 and the third 90. But the first 90 is where we're having a little
What
bit
do you mean by 90?
Okay.
90.
Yes, 90.
Yes, what does it mean?
The joint, the UNAIDS set up these targets globally, whereby you have the 3 90s, the first 90 days, as Peter was saying, is issued to knowledge of status. Like how many people who know their status. Then the ones who know their status, then you ensure that 90% of the ones who have known their status, you link them to care. And then the ones you have linked them to care treatment, that at least 90% of them, they should attain the virus suppression. So that means that as a country, in comparison, I think in 2012, we were at 56% in the first 90, 76% in the second 90, and that 90 we were at 76%. That's for the adults. However, currently we are at 80%, the second 90 we are at 96%, and that 90 we are at 90%. So we are doing quite well. Where we have a challenge, as I've said, is between the ages between 0 to 14, and we are doing something about it. However, still, in the first 90 of the people who need to know their HIV status, we know males, men have, we have an issue of, it's a bit lower comparison to women.
Well, yeah.
And so, like HIV self-testing is a very a good intervention that will make them be able to know their HIV status. Yes.
What about in terms of stopping new infections? What can we do about that?
Well, prevention is probably one of the more challenging areas of HIV programming. I think ensuring we achieve the 390s or even going beyond and getting to 95, 95.
Is it possible? You'll tell me
it's
about
absolutely possible. I think if we get to those levels, the viral suppression, basically, if somebody has achieved viral load suppression, it's very unlikely that they'll transmit the virus to somebody else because the virus is just not circulating in their body to be able to transmit it. So treatment itself is a very effective prevention intervention, but there are other interventions as well that are important. Medical male circumcision is another intervention that has been scaled up in Kenya to reduce the risk of acquisition of HIV among men. PMTCT, we talked earlier about reducing the risk of a mother transmitting the virus to her infant. That's another very important area of prevention. And then, you know, the start of that whole cascade of getting someone to viral suppression is knowing your status. And that's why self-testing, as Dr. Ngugi just mentioned, is so important. Finding new ways of ensuring that everybody who's HIV positive learns their HIV status.
In terms of, you know, access to the self-testing kits, how accessible are they to a majority of Kenyans? Because the argument has always been the cost.
Cost is only for those who want to access it using the private, the private health facilities, which is at 500 shillings. But within the public health facility, it is free. Yeah, it is free.
It is free.
Yeah,
so people can be able to get it.
Yes.
All right. Let's talk about the statistics, by counties. Perhaps which was the highest in which county and which was the lowest?
We had several who had the ones between 0.1% to 2%. Several of them like Garissa, Kiambu, Tharaka Nithi. There were that Samburu, Marsabit, especially the northeastern ones had between 0.1 to 2%. The ones who had the highest, more than 10%, we had like 4 of them. We had Migori, Siaya, Kisumu, and Homa Bay. Yes,
okay.
They had the highest, yes.
So what can the counties that had the highest prevalence rate, learn from those who are recording almost 0%?
Well, I think prevalence, once the prevalence is high, and it's been high in Western Kenya around Lake Victoria for a long time, we don't expect it to go down overnight. In fact, we don't want it to, because if it did, it would mean that people living with HIV were dying. We want to keep them alive and get them on treatment, and if they're on treatment, they should live a long and healthy life. So we don't expect the prevalence to fall rapidly in those high burden counties that have historically had a high prevalence. What we do want to see, though, is we don't want new counties, up and coming counties in terms of HIV prevalence. So I think we do want to keep an eye out for any sort of hotspots where we see a rapid increase in prevalence.
Even as you keep track of what is happening in terms of sensitizing the public, what really do you want to do as the Ministry of Health to try and focus on prevention, like he's indicating?
Mostly, I think we'll continue with the several prevention strategies that we have, and ensuring that we encourage people to know their HIV status, and the ones who are HIV positive, that to ensure that they are linked up to care. But as I have mentioned, that we have a special group, the adolescents and young persons, that they need, we are having developing ways and designing ways to see. We have several programs in the country that have been piloted and they're having good results. So it's to ensure that we scale them up, we can scale them up in the whole country and ensure that we're able to reach out to this group so they can know their HIV status and be linked to care. Yes.
In terms of funding, that has always been one of the major challenges when it comes to research and also some of these ways of intervention. What really is the long-term plans in terms of sustainability of funding towards HIV and AIDS?
Well, I think that's an important conversation right now about how to sustain the HIV response and the funding for HIV. The U.S. government, of course, has invested very heavily in the HIV response worldwide, but specifically in Kenya, and we continue to do so. I think we're also, though, speaking with the government about how transitioning the services to the services are already delivered by the counties, they're delivered by the government, but transitioning, as you were saying, that financing and ensuring that it's really a county and a nationally owned response is really important. And will be, I think, an ongoing discussion in the coming years.
What should we expect to see? Because there's always been the argument that once the donors or partners rather hand over to Kenya or whichever country that they were partnering with, it tends to go backwards as opposed to forwards.
Not really. I think first of all I want to thank the Minister of Health leadership, starting the Cabinet Secretary, the Principal Secretary, and the Chief Administrative Secretary. They have taken leadership in regarding the transition of HIV and STI programs in the country. And as we talk, the talks are in a high gear to ensure that at least when the transition, we have a roadmap in transitioning some of the services. But even as we talk, we have already started transitioning some of those areas, especially like in some of the commodities, to ensure that we are not caught off guard, but we are already preparing discussions. And we thank the US government for the funding and for the support that they keep offering, not only to Kenya, but to the whole world that are affected by the HIV program.
Yes. So how are you working with the county governments, given that health, is a function that has been devolved to the counties?
In every discussion that we have, even in the transition discussions, Council of Governors is always part and parcel of the discussions. So as we work in conjunction with them over even as now as we are planning on in any other funding, not only I think in PEPFAR, but even in Global Fund, we ensure that they are part and parcel of the discussions.
Okay.
Yes.
In terms of the scientific facts from this particular research, what can you say perhaps are the merits and demerits?
Well, I think as I was saying before about the quality, this FIA project in general and KenFIA, we implemented very rigorous quality standards, ensuring that the blood that's collected in the field makes it to a laboratory, to a freezer within 24 hours. As I mentioned, returning the results immediately in the household for the testing that's done in the household. The fact that we were able to cover all 47 counties, that we had a good response rate, a better response rate than we had in KAIS, in fact, of 77% that Dr. Ngugi mentioned. So I think we've done a lot, and even the involvement of the technical experts from the National Bureau of Statistics in the weighting of the survey results and the analysis, I think, has been helpful. They've been important, really, to make sure that the results are reliable and we can use them as our statistics going forward for Kenya.
All right, our time is running out, but looking forward and just based on the findings from this particular report, how do you intend to implement them as the Kenyan government?
As I mentioned a bit earlier, is looking at the numbers, as we have explained to you, is looking at them and seeing what is our gaps and what do we prioritize. For example, the 390s that we have given you, shown you the results, we know we have a gap in the first 90 and in the third 90 of the children. However, we are now, we have achieved some of the 90s, the 1990, the second 90, the third 90 we have achieved for the adults. So now we are pushing higher the targets to 95, 95, 95. Yes.
Have you put a time frame when you want to get to it?
We are hoping within the next 2 years that we can achieve that. It's achievable, especially now we have antiretroviral regimens that are able to help us to be able to have the virus suppression within a very short time. So that's good. The first 90 for getting our people, Kenyans, to know the HIV status is where we have a bit of a gap, but we know that we'll achieve that within maybe 2-3 years from now. Yes.
All factors considered, Peter, do you think it is possible for us to end HIV?
I think it is entirely possible if there's the political will and the ongoing investment, and through the actions of the healthcare workers on the ground and the people living with HIV, everybody, it is possible to bring the epidemic under control and ensure there are no new infections of HIV.
So what would you expect from the Kenyan people in this continued war? Because it's all about the people at the end of the day.
Yeah, I think it's we look at the achievement and we should be proud of it.
Yeah.
Because we have come from far, whereby some of those counties were at more than 25%. So now we are at less than 19%. So we have gone a long way from where we were before. Is that I would urge Kenyans that go out, be tested, can be tested in the public health facilities or in the private. There's HIV self-tests that can be done. And when you are diagnosed HIV positive, it's not the end of the world. Just be linked to care and then live your normal life. Yes.
All right. Thank you both very much for coming to studio and shedding light on this particular survey and what really it means in terms of guiding policy going forward. We appreciate your time.
Thank you so much.
Well, we have been talking to Dr. Catherine Ngugi, who is the head of NASCOP at the Ministry of Health. We also had with us Peter Young, who is from the U.S. Center for Disease Control and Prevention, just giving us insight from the report by the Kenya Population-Based HIV Impact Assessment that is showing at least the numbers are going down, and it's important for you to remember the 90-90-90 rule. All right, this is where we put a cap on your health, but of course, Betty Kiptum is up next with the day's business.